everyone. My name is Dr. Ayesha. I am a medical officer. And first of all, I would like to thank California Institute of Research and Technology for providing me with this opportunity to present at their symposium. And I'm also grateful to my mentor, Dr. Bernie, who has been there throughout in this journey. And today, the topic of my presentation is an unusual case of a ruptured appendix that underwent spontaneous resolution. So, starting off with the introduction to appendix, I think it's a very common disease, and most people are aware of acute appendicitis. It's just a small tubular structure attached to your intestines and specifically the cecum, and it can become acutely inflamed in case there is any fecal obstruction or any lymphoid hyperplasia or any bacterial or viral invasion. So when the lumen gets obstructed, it gets inflamed, and the inflammation, if left untreated, can result in either an appendicular abscess, an appendicular mass, and it may even rupture. So that was the case with our patient who had an acute appendicitis. So today my patient is the patient I'm going to talk about is a 38 years old female who presented to us in surgical emergency with altered sensorium, and her main complaint was pain in the right eyelid fossa for 4 days, which was preceded by acute episodes of vomiting and diarrhea for the last 7 days, which made us suspect it as acute gastroenteritis in the beginning. However, her vitals were unstable, indicating a hypovolemic shock. But her blood pressure was 90/70, her pulse was 98, and her respiratory rate was 16, her stats were 93%. On examination of the abdomen, she had an umbilical hernia, and which was reducible, and the bowel sounds were absent, and the abdomen was very tense and tender, and it was rigid. The pain was significantly present in the right eyelid fossa. And the LMP of this patient was 28 days back. So after, she did not have any comorbid conditions. Her past medical history was insignificant. However, her past surgical history was significant for 4 cesarean sections. And I'd just like to take a break. The section was done. And her last C-section was done about 15 years ago. And after initial resuscitation and stabilization, the patient's pulse persistently remained ready, which was about 54 to 60 beats per minute. Now, we ran some initial routine blood tests. Her CBC showed a hemoglobin of 11.5, and her total WBC count was strikingly high. It was 37,000, making a diagnosis for sepsis. And her differential neutrophil count was 93%. And the first organ to shut down in sepsis is definitely the kidney. And so her renal function test did not turn out great. Her creatinine was 5.4, and her potassium was also borderline high, 5.1. And this made us think of acute kidney injury due to prerenal cause, sepsis, and the dehydration she had been having for the last 7 days. So we started her on IV fluids, IV antibiotics, and the rest of the supportive treatment, including antiemetics and analgesics. And because the pain was in the right eyelid fossa, it also made us suspect acute appendicitis, but the low pulse did not indicate the same. So we did an ultrasound abdomen, and on ultrasound, her liver, gallbladder, pancreas, and spleen were normal. However, the ultrasound showed that the kidneys, they had bilateral increased renal parenchymal echogenicity, indicating kidney failure. And because this patient was in altered sensorium as well, and her hyperkalemia was refractory to treatment, unfortunately, she had to undergo dialysis to correct the hyperkalemia as well as the acidosis. And on a repeated ultrasound scan, what we saw was dilated bowel loops, which on the repeated ultrasound scan, we saw dilated bowel loops with loculative fluid seen in the right eyelid fossa and no peristalsis. Her ECG was normal, and an X-ray abdomen was done, and The X-ray also showed multiple dilated bowel loops, but no air fluid levels. That means we ruled out an intestinal obstruction. But the only ambiguity was we were still not sure if this is acute appendicitis or there has been a perforation leading, a typhoid perforation leading to a generalized peritonitis. And because this patient just suffered from acute renal injury, so we could not perform a CT with contrast. However, we got done it without contrast. And on the CT abdomen, it showed appreciated divertication of recti. No bowel related mass was seen, no ascites, no fluid. And the only no abdominal pelvic lymphadenopathy was seen. And just 1 minute, you can, I think, cut this part out. I'll restart the CT abdomen. There is appreciated divertication of recti, no ascites, liver hormone size, large. All right. So we did a CT abdomen with without contrast, and there were no significant findings indicating either acute appendicitis or a typhoid perforation. The CT abdomen only showed that there is divertication of recti, the liver is normal, spleen is not enlarged, and pancreas appearing unremarkable, and no abdominal pelvic lymphadenopathy seen. So after initial resuscitation and starting the treatment, so on the fourth post-op day, the patient started showing some signs of improvement, although she had not passed any stool of status until the fourth day, and she was only getting the conservative treatment for it, that is the IV fluids and IV antibiotics. This patient, who is 38 years old and presented to us in the surgical ER with the initial presentation looking like an acute gastroenteritis, and on further probing it, because on further probing and examination, it appeared to be generalized peritonitis, and we could not pinpoint what exactly caused the peritonitis. And the pain, she had severe dehydration, which led to hypovolemic shock and ended in sepsis because of the perforation. And however, and the patient was in altered sensorium. She got the dialysis done, and even on the fourth post-op day, she had not passed any stool of status, but she did respond and eventually improved. And on the fifth post-admission day, she did pass her stool and status, and ultrasound abdomen remained inconclusive, and the CT also did not signify any changes. And the tenderness in the abdomen also improved, and this was eventually concluded to be a case of ruptured appendix, and which responded to conservative treatment. So the conclusion that we have from this case is that it's not so the conclusion that we have from this case is that acute appendicitis can present in a variety of ways and has numerous presentations depending on the age and gender of the patient. And usually in the females, the right eyelid cause of pain could indicate a typhoid perforation and acute appendicitis in ectopic pregnancy or ovarian torsion, all of which were ruled out. She also had a urine pregnancy test done, which came out to be negative. So we could rule that out. And it might also be a pelvic inflammatory disease, but she did not give any history of any vaginal discharge. And this case particularly reflects the importance of conservative management and observation in such patients. And had she not been in sepsis and suffering from AKI, she would definitely have undergone an appendectomy for this. But because she was widely unstable and already in AKI, this could not be done. And we just waited and started the conservative management, and resuscitated her with the IV fluids and IV antibiotics and kept monitoring her. And this case was also unusual in the sense that she persistently had a slow pulse, and her ECG, although was normal, except the sinus bradycardia, and only the bradycardia raised the suspicion for a typhoid perforation, but obviously could not have resolved spontaneously. So this highlights the importance that it's, I think it's of prime importance. This highlights the significance and that it's of prime importance to delay the surgery and wait for some time for the patient to respond to conservative management and be vitally stable. So crucial importance to be vigilant, And at the same time, it's also of crucial importance to be vigilant enough to diagnose common surgical emergencies and make a diagnosis well in time to treat the patient to the best possible outcomes. And with that, I conclude my case presentation. And once again, I would like to thank California Institute of Research and Technology for providing me with this opportunity to present the case at their symposium. And thank you, everyone.